morning, ladies and gentlemen.
Good morning.
Good morning.
Morning. All you sunshiny people. I'm Cheri Teranishi, the president of the White Parkinson Association, and it's really nice to see everybody this morning back again for a repeat at this great venue. I wanted to start out by introducing a few key people from the White Parkinson community. White Parkinson Association board, if they're here, just wave your hands. I'm not sure, they're probably all out running around. Kate Kizumi, Vice President. Secretary and Head of the Exercise Committee, Lindsay Sutton. Treasurer, Russ Boyer. Board members, Pat Bemis, who's also the fairy godmother of the sport groups. Pat's floating around somewhere. Dana Barbata, who's running the symposium today. Lisa Kubota Moffat, and Fran Calvert. Here we have a few previous members. Joel Cohen from Big Island. Kevin Lockett's floating around. You'll be seeing him later on as moderator. Support group leaders from the island. Again, Russ Boyer. Nona Andrews. Is Nona in yet? Oh, there you are. Thank you, Nona. Jan Youth couldn't be with us today. Kevin Lockett. Dennis Miyamoto. Dennis is over here. Abel, you around today? No, Abel didn't. Tom St. John, off Big Island. And Fran Calvert, around somewhere. She's not in right now. Lastly, I'd like to recognize the doctors who treat us. Dr. Webb Ross. Thought I saw him come in. Oh, there you are. I had no problem on the other side. Dr. Melvin Yee. Haven't seen Dr. Pang this morning. Dr. Stuart Pang. Dr. Sarah Grainer. Dr. Grainer this morning. Not seen her. Dr. Pat Borman. Most folks know Dr. Borman. And then I haven't seen Dr. Vera yet this morning either. Probably joining us later. Dr. Ross and Dr. Borman, would you please join me? Dr. Ross is from the Pacific Health Research and Education Institute, and Dr. Borman is from White Pacific Neuroscience. The last few years we've been proud to provide them research grants, which we're going to do again this year. We've been able to up it a little bit this year from $2,500 to $3,000. And these grants assist patients coming in from neighbor islands to participate in the studies here on Oahu. So let me see, one for Dr. Ross. One for Dr. Ross.
Well, if I can just take a second to express thanks from Hawaii Pacific Neuroscience. We're very happy to be helping all of the island residents with Parkinson's research and research in a lot of other neurologic diseases as well. And these monies really do make a difference for our outer island patients that want to become research subjects. So we're always getting new Parkinson's studies, new studies of all sorts. So keep the research center in mind, and hopefully we can find a cure.
And the way I look at the research, the studies and trials, is if you want to have a crack at the latest and greatest in medications and studies, the latest and greatest technologies, these are the events that you want to be part of. There are some downsides, but there's more upsides than there are downsides. That's why I've been in study. How many have I been in now? 2 or 3 or 4 or something like that. Besides the centers, there's also studies that go on online. I'm part of about 6 online observational studies, as well as studies under Dr. Ross, and there's going to be more to come. And along that line, when World Parkinson Congress is coming up in June, and Hawaii is going to be well represented by a number of us that are going out, and I'm going to be meeting with quite a few of the drug companies' front offices, and one of my requests is to try to bring in more dollars in the form of research dollars to Hawaii, because the critical pieces in research is having volunteers. And so far, Hawaii has been very good about people stepping up to be part of the studies, but if we bring in more studies, we're going to need more folks to step up. Again, it's cutting edge stuff. Enough of that. You can talk to Dr. Ross or Dr. Borman on a break or afterwards, and they'll be more than happy to talk to you about the specific risks and benefits. But just needless to say, I'm a big advocate. Anyways, Mr. Cohen, would you come up for a minute?
Can I bring my wife on?
Sure. Just want to take a minute and recognize Joel Cohen from Big Island. Joel's been, he's an outgoing board member. because he's decided to leave our presence and actually, you want to stay down? Or you coming up?
Carefully.
Carefully. He's actually going back to the mainland, moving back to the mainland to be with friends and family. And Joel is, for those who know us, is kind of my partner in crime over on the Big Island. And we talk a lot back and forth on how to get business done, because for those who know me, I'm a military officer. I'm used to doing business one way, which is to give orders. And that's not how an organization like ours works. Ours is being a nonprofit and a volunteer organization. I've had to make quite a few adjustments, and Joel has been my wise mentor and counsel for so many events. So I wanted to take a moment and recognize Joel, even though he's only been on the board for a couple of years. He's been a key mainstay for me, and I want to say mahalo nui loa.
Thank you. And I have up my wife, Phyllis Terrell, who basically is my partner in everything that we do, including co-leading a support group in Waimea on the Big Island. And so whatever I've accomplished, she's been there for me and with me.
Great. Okay, Nona, come on up. Nona has no idea that we're recognizing her as well. Nona is the Hawaii Kai caregiver support group leader, but she's a whole lot more than that. She's a bundle of energy in a lot of things we do. So we're recognizing her this year as a volunteer of the year. And and this is from a local artist, and it's a lighthouse because she's a beacon of light for so many in the Parkinson community. And lastly, of course, I need to thank all of our sponsors for their generosity in making this event possible. So at silver level, we had St. Francis Healthcare, Adamas Pharmaceutical, Abbott Pharmaceutical. Bronze level, FV, Acadia, Accorda, Lundbeck. In-kind sponsors, iHeartMedia, Menehune Water Company. So if you need water, there's free water out there. Please help yourself. Keep hydrated. One thing to keep me up for, then Altrez for all the bags. So with that, I decided to keep it short. Enough paid political announcements. So I will kick it over to Dana for the rest of the program.
I'm Dana, and thank you for having me here today. I'm very honored to be speaking about a topic that is not talked about very much in the community. So bowel bladder dysfunctions is actually very common, but we do not discuss it for fear of embarrassment, fear of being told there's nothing that can be done for you, but really, there's a lot that we can offer for you in helping with these types of dysfunctions. So let's talk about bowel and bladder dysfunctions and treatment strategies. So urinary incontinence or urinary dysfunctions is very common. And you know what, I'm okay with me walking around. I like standing up here, so I can walk around. Okay. But basically, urinary dysfunctions or difficulties, it's very common. And it includes urinary leakage, urinary frequency, urgency, increased urination at night, so having to wake up more than what's considered normal. And about actually 80% of patients that are diagnosed with Parkinson's disease go through some type of challenge throughout this disease process. And the thing is, understanding why these things are happening to you is the key to success and how we can try to help improve your quality of life, not just for you, but also for your caregivers. There are strategies that we'll talk about today. And because we are limited in time, I'm going to do my best to cover what I can. But please feel free to reach out to any of us that work in this population and this type of specialty area to find other resources for you. When we talk about pelvic floor rehabilitation, what it does is we can actually help, like I mentioned, improve your quality of life. for any of you that have problems, even without Parkinson's disease. In the general community, 80% of all women have some type of urinary leakage or frequency problem, about 20% of men as well. And it's just because it's a matter of aging. Our muscles get weak as we get older. If we don't strengthen them like any other muscles in our body, they get weaker. So the first thing that we're going to talk about is constipation. In Parkinson's disease, constipation is probably one of the biggest concerns or challenges with the bowel system. How does our bowel system work? Basically, we eat our food, it goes down into our stomach, things get digested, the feces go into what we call is our small intestines and then into the colon. But how do our feces move through our system? Basically, it's moving through what we call as peristalsis, or waves, which are contractions of the colon. And basically, as it contracts along the colon, it'll slowly move our feces along. However, what happens in the case in our patients with Parkinson's disease, that motility slows down. And so we end up, yes, with problems with constipation or decreased bowel movement. Usually, our peristalsis motions happen about 2 to 3 times a day, and it is triggered by eating something. The other thing is also having warm drinks or fluids that stimulates our system as well, and movement. Now, I know you probably don't want to be looking at stools this early in the morning, but it's very important to know what's normal, okay? And this is a Bristol stool chart, which I do show to all of my patients because I want to know what's happening, what's going on. Because how your stools look, believe it or not, can tell us how we can help you. Whether it be we need to increase fiber in our diet, whether it be we need to increase fluid intake, or whatnot. So if you're looking at the different types, type 3 and type 4 there in the middle, here, those are considered normal. But if you're coming out with stools that are little balls or little BBs, that's definite signs of constipation, and we really need to take a look at what's going on. As compared to the other side, or more on the runny side, what do we have to do with your diet to help you in that case too? Okay? Because a lot of you know if we end up on type 6 and 7, sometimes we might have problems with some fecal leakage. And how do we help prevent that? So looking at constipation, basically constipation, the diagnosis is difficulty with evacuating your bowels, usually with hardened stools. So what are some of the causes related to Parkinson's disease? Decreased motility of the bowels, like we talked about. And this kind of goes hand in hand with the next thing that we'll be talking about, is decreasing our fluid intake. Why? Because we don't want to go to the bathroom so often, or we don't want to have urine leakage. But decreasing our fluid intake will cause problems with our bowels, right? Because we're going to be dehydrated, bowels are going to get harder, firmer, going to be harder to get out and move along. So how can we help with constipation? What can you do? So on a daily basis, just increasing your activity and increasing movement will help to stimulate your bowels. So if we're just sitting down, not much is happening to our system. Once you get moving again, you'll notice that's when things start to move. Hydration is very, very important, like we talked about. So making sure that you do get the recommended amounts of fluid. Drinking warm liquids in the morning can also help to stimulate your system. Okay? But keep in mind, warm liquids, look at that next line, avoid caffeine and alcohol. So caffeine, a lot of people drink what in the morning? Coffee, right? But coffee is actually going to dehydrate you. So it is a stimulant where we're going to increase urine production. We're going to get rid of more urine quicker. We're going to dehydrate ourselves. So it kind of goes hand in hand where we want to drink warm liquids, so there's other options for you. Dietary choices, and I believe we have some of this afterwards. That's going to be talking about some dietary things. But you do want to think about eating more fiber-rich foods, things that can kind of bulk up the stools. So your fruits and vegetables, your legumes, whole grains and cereals. Things to bulk up the bowels to help it move a little bit easier through the system. So one strategy that I like to teach my patients, has anyone heard of bowel massage before? And how to stimulate? Okay, got a couple hands. So this is very important, it's something that we don't think about. This is what we teach to new parents with babies that have problems with constipation, but it works on us adults too, okay? So with the bowel massage, we are stimulating the colon to help move the bowels along. And how you would do this, let me come up here, is usually our food will travel here from the ascending colon, so it comes from the small intestines. Ascending colon travels upwards on the right side here of our body, right to under our rib cage, comes across the bottom of the rib cage through what we call as the transverse colon, comes down the descending colon on our left side here, and then out through the rectum. So how you do the bowel massage, I like to teach my patients to actually start here on the descending colon coming down, because we want to kind of clear out what's there. So the techniques that you can use are two things. You can either do a gentle circular massage coming downwards, following that colon path. So coming down the descending colon, and then slowly coming around, where you're going to come back up on the ascending side. Sorry, I see people behind the poles. Coming up on the ascending side, across the transverse colon. We have to go in this clockwise direction. So that is the one takeaway I want you to remember. Clockwise direction is key. If you go the other way, you're going to back yourself up. Okay, and that's not good, right? You're trying to get things out. So clockwise. So you can also do light stroking, you know, to stimulate the bowels. So that's one technique that can also help to stimulate your bowel movements whenever you feel stopped up or whatnot.
I have a question.
Yes.
How much pressure should you use on that massage?
How much pressure should you use on the massage? It's a gentle pressure, depending on what you can tolerate. It's a gentle pressure, almost like you're pressing down to feel a baby's belly. So it's a gentle pressure. It's not where you're squeezing it out and trying to push everything out. And I can show you after. It's a very light pressure. Moving on to bladder function. So this depicts our normal bladder function. When we look at our bladder, how it works is we have our bladder here, which is made of what we call the detrusor muscle. So it's its own muscular sac. Base here of the urethra, which is a tube that empties from the bladder to the outside of the body, is our pelvic floor muscles. So those pelvic floor muscles are the ones that we can control to help us to stop urine from coming out when we want to go to the bathroom, or to help urine from leaking. So those two work hand in hand. What you can see is as the bladder starts to fill, the sensors in the bladder muscle and the detrusor muscle signal, and they kind of contract a little. And that's what gives us the first urge to void. So when you feel that sensation like, oh, I need to go to the bathroom, I need to empty, it's because that bladder muscle is contracting. Most of us can get distracted, we forget about it, we get busy doing something else, and we move on. A couple hours later, maybe, that bladder is filled up to a greater capacity, and it's saying, I need to go now. What happens in the case of the bladder and the pelvic floor muscles, they work hand in hand. However, they work opposite of each other. So when one structure is working, the other one has to be turned off, and that's how we're able to void. When our bladder muscle here says, I need to empty, it starts to contract. And then as our brain tells our pelvic floor muscles here on the bottom, hey, relax, because I want to empty. And that's how we're able to void and urinate. And so that's just our normal bladder function. Now when we look at what's normal for bladder function, the first urge is usually felt at about 5 ounces of bladder filling. And like we mentioned, you should be able to delay that void up to about 1 to 2 hours after that, before we really need to go. Because a normal voiding amount is about 8 to 10 ounces of filling. Do you know how much our bladder can actually hold? Kind of plenty. It's actually about 2 cups of urine. So that's quite a bit, so about 16 ounces. But daytime frequency is actually anywhere between 5 to 8 times a day. And so for some people that's like, oh my gosh, that's a lot. But that's actually considered normal. Voiding duration, so the time between trips to the bathroom can be anywhere between 2 to 4 hours, is considered normal for our bladder. Granted, it's depending on how much fluids you are intaking, so we want to keep that in mind. Nocturia, or waking up at night to go to the bathroom. What's considered normal is 0 to 1 time at night. Granted, if you've got some other health conditions going on, that may increase as well. We'll talk about that in a little bit in the patient-treated Parkinson's disease. Urinary leakage, we should not have any urinary leakage, okay? Any type of leakage means something's going on with our system that we need to figure out how to help. Color of your urine, when you look, okay, I already said you gotta look at your bowels and your doo-doo, right? Now I want you to look at your urine, okay? The color should be light yellow to clear. If it is darker in color, or if it's a little smelly, that means you're probably more on the dehydrated side, and you really need to increase your fluid intakes. So with bladder symptoms, incontinence or urine leakage can be caused for a variety of reasons. And I wanted to discuss them because they're not readily discussed in a lot of doctor's visits or even in therapy with your therapist. The different types of incontinence that we have, stress incontinence is probably one of the more common terms you'll hear. Stress incontinence means there's been some type of pressure put on our bladder or urinary system. So like with a cough or a sneeze, or you bend over to pick something up. The bladder is getting squished, or there's pressure being put on that bladder, but the pelvic floor muscles below don't have the strength to keep that urethra closed against that pressure. So we're gonna have leakage. So stress incontinence doesn't have anything to do with mental stress. It's more a physical type stress condition. So learning how to strengthen those muscles are going to be key. Urge incontinence, on the other hand, is when you get that feeling or the sensation like you need to go. And, oh my gosh, I need to get to the bathroom right away. I am running to the bathroom. Sometimes I am leaking on the way to the toilet. What's happening there, it's more of that bladder muscle or that detrusor muscle that's kind of doing its own thing. It's contracting and spasming, and it's not listening to you. Mixed incontinence is a double whammy. So you've got stress incontinence plus urge incontinence combined. So you've got weak pelvic floor muscles plus a bladder that's kind of doing its own thing and not listening to you. Overflow incontinence. This is where someone may not get the sensation that they need to void or appreciate that urgency, or sometimes there may be something blocking the outlet where that bladder will fill up and fill up and fill up, and there's nowhere else to go but out or back up into the kidneys. Functional incontinence. Now this is where we have some type of physical function or decrease in physical abilities to get to the toilet in time. So maybe we had knee surgery, now we're on crutches, and our bathroom's across the room. We can't get there fast enough. Or with Parkinson's disease, it is common, right? At night, we have difficulty, it takes us a little longer to get out of bed. So it's not the part of the muscle is not working right initially, it's just being able to get there in time. That's what functional is. Iatrogenic is if there's some type of other medicinal, drug, or medically related intervention that can contribute to your symptoms. And neurologic is if something's happened to our neurological system. So in the case of someone with a stroke, with a spinal cord injury, and also with Parkinson's disease. Now when we look at our urogenital or our bowel, our bladder function here, and our system. So we have our female system here. So we have the bladder here up front, right behind our pubic bone. Uterus is right behind, bowels are even further back. The pelvic floors are here at the base of the pelvis. As compared with men, we have bladder here. Men have the prostate gland a lot of times, which is extra support for the bladder. And so that's why we have less urinary leakage problems in men usually. Pelvic floor though is the same, starts at the pubic bone, runs at the base of the pelvis, attaches to the back and the tailbone. So with the sphincter dysfunction, so stress incontinence, the sphincter dysfunction means that we've got weak muscles that can't keep that urethra closed. So we're going to have to learn how to strengthen those muscles. As compared to what we talked about was urgency, frequency, where that detrusor bladder muscle is doing something. That's where that bladder itself, we have to teach that bladder how to listen to you again. So if you remember when you're a baby, you have no idea what's going on. You're peeing and pooping whenever you want to. Until that brain spinal cord pelvic floor muscle connection gets made. And once that gets made, that's when our parents or whoever is able to potty train us. So voiding is actually something that we are taught, and we can relearn that. So we can re-strategize and teach you how to tell your bladder, hey, listen to me, I'm the boss, okay? You don't be telling me when to run to the toilet. So that's the beauty of our system. And again, mixed incontinence is both. So we have to strengthen your muscles and teach your bladder how to listen to you. So looking at non-urogenital causes, so nothing related to the pelvic floor or the bladder. These things are very important with a lot of our patients. Communication. Are you able to communicate that I need to use the bathroom now? Or is that communication lines open? Mobility, being able to assist to get to the toilet in time, or getting on and off the toilet, or even being able to use an appropriate device. So are you able to hold and grasp and help with a handheld urine bottle to void? Things like that we have to keep in mind as we're planning out how we're going to help our patients. Cognition. You get that urge sensation, do you know what it means? Okay, so that's something that we don't think about. If you get the urge, are you able to say, hey bladder, wait, I'm not ready yet? And also be able to initiate voluntary voiding. What that means is when you go and you sit on the toilet, are you able to say, okay, empty? We don't think about it, right? We just sit and it happens. But when you have some type of process that affects your nervous system, it becomes more challenging, where now we really do have to think about what's happening and how our muscles need to work with us. So some incontinence or leakage treatment strategies, like I said, there's a lot, and because I'm limited on time, I'm just gonna pick the big ones. So pelvic floor muscle strengthening, or also known as Kegel exercises, same thing. Okay, pelvic floor muscles don't mean that you need to get on the floor to do these exercises. Just means we're strengthening the pelvic floor at the bottom. And I mentioned that because I've had patients ask me that, So I want to make that clear. The pelvic floor muscles here, you can see on the right-hand side of the slide, they are very thick. That's how we need them to be. They have the strength to close out that urethra. As compared to our weaker muscles shown on the left-hand side, you can see that they're a lot thinner. They're atrophied, as our muscles typically do when they get weaker, and they can't create that strength to close off the urethra. So how do we strengthen those muscles? Is through the Kegel or pelvic floor strengthening exercises. Also, bladder calming or relaxation techniques. How do we get that bladder to calm down and listen to you again? So there's treatment strategies for that, but it goes back to the first one here. The stronger we can get your pelvic floor muscles, the easier it is to calm down your bladder. So how I said the bladder and the pelvic floor muscles work hand in hand and kind of in tandem. What happens is our bladder contracts, our pelvic floor goes, okay, I need to empty, I'm going to relax. So to be able to stop that, if we are able to learn how to contract our pelvic floor properly and strengthen those muscles, it does send a signal up to our brain to say, hey bladder, calm down, stop contracting because I'm working down here. And once we can regain that strength, we can try to help with decreasing that urgency, and then you can slowly make your way to the bathroom without fear of leakage, without fear of rushing. Bladder training is learning how to put your bladder on a set schedule, and we'll talk about that. One common thing with Parkinson's disease is increased urinary frequency. And so that is voiding more than what's considered normal, and not necessarily due to the increased fluid intake. So causes related to Parkinson's disease. So it is related to some receptors in our brain, in the basal ganglia. And it actually, those receptors control our voiding patterns and our voiding reflexes. But with Parkinson's disease, it has been shown that one of those receptors is actually kind of underactivated. And so it inhibits the voiding reflex, so it cannot inhibit it. So that's where we're going more frequently. We have a little bit more challenges in helping to control that. So some of the strategies for that, okay, is the bladder training like we mentioned. So getting your bladder on a set time schedule. So believe it or not, like I said, we can retrain your bladder. From the minute you wake up, you're going to go to the bathroom and empty. At a set time interval after that, depending on the program that we're working on and where we want to get you to, you're going to head back to the bathroom and void, whether or not you have the sensation to go. Over time, that bladder starts to relearn that, hey, I'm no longer in charge. You're the one that's taking me there and telling me to empty when you want to. And so slowly we can start to increase that time interval between trips to the bathroom and get you to a better duration or period between your voids for you. The other symptom that we see a lot is nocturia, or going to the bathroom at night, more often than not. And a lot of times is the contributing factor if we have increased swelling in our legs for some reason or another, or increasing fluid intake at night. And what happens is, when we have increased swelling in the legs, right, when we lay down at night, gravity is no longer pulling all that fluid into our legs. So we lay down at night, that fluid tends to come out a little bit easier, so we're going to go to the bathroom more frequently at night. So some of your strategies for that is to put on compression socks or compression garments a couple hours before bedtime. Or get those legs up, elevate them, try to get that swelling down a couple hours before you go to bed. So there's not as much fluid that's going to come out when you're sleeping. Also making sure that you try to decrease your fluid intake at least a couple hours before bedtime, and then emptying your bladder right before you go to bed. So just a few strategies to help with that. And like I said, there's a lot of different other options, but time is limited, so I'm not going to be able to cover them all. If you do have other questions or need more one-on-one individual treatment or assessments, please reach out to someone that's treating this type of conditions or this specialty area, because there really is help for you. And every session or every treatment option, it's individualized to you. It's not a cookie cutter, okay, you've got this condition, this is all we're going to do. So this is my contact info, and we have a booth outside as well that we have some information about our program and my business card too.